Good evening, friends. I welcome you all for this yet another exciting webinar arranged by the Greater Pune chapter of SFM. The idea behind this, as before, the series has been to talk about cases which are slightly normal, slightly abnormal, which are on the cusp of being normal or abnormal, and how to approach these cases and how to go about reporting them, counseling the patients, so on and so forth. We're fortunate to have three big names in fetal medicine today guiding us on this webinar. Like last time, we have based this on case-based reports. So initially the case will be presented and the expert, our panelist, will talk about it and guide us further in this regard. We start with Dr. Asha. She will be presenting a case of a spectrum actually of hydronephrosis, fetal hydronephrosis, and Dr. Aparna Sharma madam will guide us further on how to approach these cases. The second is somewhat an unusual case, that is a binder's syndrome, which is not usually commonly discussed in webinars and seminars, and we thought of including it here in today's presentation. And Dr. Unmesh will be presenting this case, and our Dr. Bimal Sahni sir will be talking about it and guiding us further in this. And the last of the lot is that of an absent ductus venosus, a case of absent ductus venosus. We do come across absent ductus venosus now and then, and it is always challenging to diagnose it as well as to approach the case and counsel the patient further in this regard. And Dr. Bijoy will guide us in the last case. I'm sure that all of us will enjoy this webinar. I wish all of you a very happy Diwali in advance and happy learning. So let's begin with Dr. Asha.
Good evening, everyone. I would like to confirm that my slide is seen and I'm audible.
Yeah, no problem.
Good evening, everyone. I would like to first thank the Greater Pune chapter of Society of Fetal Medicine for giving me this opportunity. Now, moving on to my cases, a seemingly innocuous finding that has the potential to resolve or exacerbate into something serious. That is mild pilectosis, a story that can be trivial or tragic. Today, I present to you some of my cases that started with the same ultrasound finding of mild pilectosis, but had very different endings. Now, the term that I'm using here, mild pilectosis, or similar terminologies that we are used to, like pelvic alveolar system fullness, PC system fullness, pelviectasis, hydronephrosis, is being replaced by a more specific terminology of urinary tract dilatation with classification. This is to bring about a uniformity in reporting. Details of this will be covered in the subsequent discussion. At the outset, I would like to stress that when I'm talking about mild pilectosis, with regard to my cases, I am talking about urinary tract dilatation A1 type. Here, the renal pelvic AP diameter is more than 4 millimeter and in the second trimester, and there are no other findings in the urinary tract. Now, case one, the trivial to begin with, because this is what will happen to most of the cases of mild pilectosis that we come across in our daily practice. This case is that of a 24-year-old second gravida. She had a history of irregular menstrual cycles. Her repeated UPTs were negative for the past 6 months that she had amenorrhea. One day she felt some hardness in her lower abdomen and had a perception of movements. She was advised ultrasound, and when she came in, she was 21 weeks. Now we can see from this slide that there was mild bilateral pilectosis, but otherwise the rest of the anomaly scan was normal. We all know that mild pilectosis is a marker for Down syndrome, but when it is isolated, it does not really increase the background risk of the fetus. But we cannot give subjective assessments when we are dealing with cases in which the risk is so much high as to the mother having a Down syndrome baby. So we have to be objective about when we talk to a patient. So before we do that, before we convey our report, we use a genetic sonogram. In this, the positive likelihood ratio of mild bilateral pylectasis is multiplied with all the other markers that are absent in the baby to get a final combination likelihood risk combination of about 1.08. That is approximately 1. Now, to give the final risk to the mother, we need to multiply it by the background age risk of the mother, in this case by 1. Now, this means that the risk of this mother for having a Down syndrome baby is equal to that of a background age risk. Now, for this 24-year-old young mother, it is quite low. Now, it is just not Down syndrome that we are worried about, but also the progression of pylectasis into a more serious form of hydronephrosis. For that, she was counseled to come in for a review scan. At 28 weeks, the pylectasis persists, but we can see from the image that it is below 10 millimeter. So the patient was reassured, and the last scan was done at 34 weeks. There is still mild bilateral pylectasis, but the anterior posterior renal pelvic diameter is still less than 10 millimeter. This mother went on to deliver at term and had normal outcomes. This is a happy end to a story that began with a trivial finding. Moving on to my next case. This case, to start with, had the same trivial finding of mild pylectasis, but it was not, everything was not smooth as the former, but a tragedy was averted. Now, this is a case of a 23-year-old primary gravida. Her NT scan was normal. There was no serum screening done. She came for an anomaly scan. Now, at anomaly scan, she had bilateral echogenic intracardiac foci. Otherwise, the fetal echo was normal. The only other positive finding in her anomaly scan was that of mild bilateral pylectasis. Now, we know that both echogenic intracardiac foci and mild pylectasis are minor markers. Common findings on an anomaly scan, but when present together, how do they affect the risk of the mother? As I have mentioned before, we need to objectify the risk. So again, here we use the genetic sonogram. Here, we multiply the positive likelihood ratio of the two markers that we find in the fetus with all the other markers that are absent, and we get a factor of about 8. That means the risk of the mother for having a baby with Down syndrome is increased by a factor of 8. To give the final risk, we need to now multiply it by the background age risk of the mother. So the final risk that we got was that of 1 in 177, which clearly means the mother has a risk of Down syndrome above the cutoff, which is 1 in 250. She was advised to undergo an invasive testing, and amniocentesis was done. This baby was found to have trisomy 21, and the pregnancy was terminated. The same mild pylectasis, now it was not so trivial, but a tragedy was averted. Now, the last two cases are a face-off between two patients that began in the same manner with mild pylectasis, but ended up quite differently because of the choices each one made. Now, case 3 is that of a 22-year-old primary gravida. Her NT scan was normal. There was no serum screening done. There was mild pylectasis, which is significant only on the left side. In case of the next study, that is case 4, this was a 23-year-old primary. Her NT scan was normal. No combined screening was done. She came for an anomaly scan. There was mild bilateral pylectasis, which was more on the right side. As per protocol, they were asked to come in for a review study. On the review scan, there is mild increase in the renal pelvic diameter, now more on the left side. But in case 4, there was severe increase in the size of the renal pelvis, more on the right side. There is mild pylectasis on the left, but not very significant. But in this case, on the right side, there is ballooning of the renal pelvis as well, and also dilatation of the major calyces. In the third trimester, in case 3, the findings on right side had subsided, but there was urinary tract dilatation, A2 type in left kidney with dilatation of the major calyces. A possible diagnosis of vesico-ureteric reflux was given. Whereas in case 4, there was severe urinary tract dilatation, A3 type, ballooning of the pelvis was noted with dilatation of major and minor calyces, also with some degree of renal parenchymal thinning. In both cases, they were counseled to meet a pediatric nephrologist, and they were suggested to come in for postnatal screening. In the first case, the mother was very diligent. She brought in the child once at 1 month of age and the other time at 6 months of age. At both times, the hydronephrosis was found to be persistent, also with some prominence of the ureter. So again, a possibility of vesico-ureteric reflux was given. Now, the pediatric nephrologist suggested her to undergo an MCU. And from the MCU report, it was confirmed that the child was indeed having a vesiculourethric reflux. This child was put on antibiotic prophylaxis, and a functional renal scanning was done when she turned 3 years of age. The functional renal scanning, the DMSA report, showed that there was satisfactory renal tubular function with no evidence of scars. Now, the image that I've shown here is that which I did of the girl at 5 years of age this year in 2021. She is now 5 years of age. We can see that there is persistent hydronephrosis. The kidney is looking overall normal with no scarring. She was due to visit the nephrologist after the study. But in case of the other baby, the things had changed dramatically. The findings had increased. This lady was also asked to come in for postnatal screening, and a pediatric nephrologist consult was taken. And here, the diagnosis which was suggested was that of a possibility of vesiculourethric reflux or that of a severe PUJ obstruction. Patient had a LSCS, and once a female child was found, no follow-ups were done. And then she was brought in for ultrasound when she turned 1 year of age, when the baby developed abdominal distension, and there was a hard mass-like feel on the right side of the abdomen. In spite of being advised to go in for further investigation and for surgery, the mother with the family decided to do nothing. This is a finding that I found in the last ultrasound that I did this year when the child was around 2.5 years of age. Sometimes it doesn't matter how diligent we are in doing our scans. The outcome will depend upon how motivated the patient is in following protocol. This distinction being very clear with about 2 cases in which one child is doing well, where the other is in agony because of the choices her parents made. Mild pylectasis, it's easy to see, simple to measure, a sign that shouldn't be ignored, not treated with nonchalance, but should prompt us to follow protocol, because we don't know how the story will end for the child, and only time can tell us whether it is trivial or it's going to be tragic. Thank you.
So, a very good evening to all of you, and I think it's been a brilliant presentation from Dr. Asha. The various cases that you've shown really shows the almost the entire spectrum that we come across in our practice. So with that, I'd like to talk a bit about hydronephrosis, trivial or tragic. Is my screen visible?
Yes, ma'am.
Yes. Okay. So thank you. And so yes, trivial to tragic. So that's the big question here. So in brief, I'd like to cover this topic across various aspects that we come across. So what exactly is the definition? And as Dr. Asha really mentioned nicely, that over so many years now, we've had so many confusions on terminology. But yes, UTD is something that we are now using, urinary tract dilatation. Now, dilation of the renal pelvis with or without dilation of the renal calyces, that is one of the definitions. And yes, we will go a bit more into it. But before that, I would like to also mention that why is there so much confusion over this terminology? Why is we are so confused on whether to call it hydronephrosis, pylectasis? Does it have any meaning over it? So the question arises because there's so much of a poor correlation between the antenatal and the postnatal outcomes, antenatal findings and postnatal outcome. Like Dr. Asha really showed, that there were 4 cases and different outcomes in each of them. Also, there is no uniformity on how to define, classify, and grade. Different terminologies have overlapping meanings. Like somebody says hydronephrosis, so for a radiologist, it could be even mild degree of urinary tract dilatation. But for clinicians, hydronephrosis is like a gone kidney. So even in our way we speak, there is so much of difference. And more importantly, it's not a static thing. One day you have a dilatation, the next day you would have less or more. And it fluctuates over time with varying condition in the baby and degree of bladder filling and the patient position. Also, uropathy is present with a spectrum of severity, and not all cases of PUV will have a severe UT dilatation. Severe urinary tract dilatation, you have a problem, but not all cases of a probable severe disease will present in the antenatal period. So it's actually an amalgamation of so many findings that that there is the confusion that really happens. So as Dr. Asha said, the currently used terminology is not hydronephrosis, not pilectasis, not kaliectasis. We generally prefer to use a simple term like a urinary tract dilatation. And that is what we would like to define more, go into the detail about what is that dilatation, where is the dilation, what is the associated findings. Now, why does this happen? So, first of all, it could be a transient thing, or of course, the next thing would be, is there an obstruction or is there a non obstructive process? So, this is the most commonly available data that is there across literature. So, most commonly, it would be a transient finding. And then the second most common would be PUG obstruction. And the third is VUR, vesico-ureteric reflux. So if we combine all of these cases, so these would be, the few cases that are accounting for majority of our cases, and the other ones are slightly less common, like PUV is 1 to 2%. So these, out of all of these, so this is not something that you go and terminate the pregnancy for. So that is something that we really need to think about, that what is happening in majority of cases. So majority of cases is the transient UPG obstruction or vesico-uterine reflux. So what is the goal of evaluation during our antenatal period is to identify those cases that may adversely affect the health of the baby or require an antenatal or postnatal evaluation, while at the same time not trying to trigger a panic among the parents that, okay, now my baby has swelling in the kidney, now I'm going to terminate this pregnancy. So that is something that we really need to understand and keep in our mind when we are evaluating. Now, transient, as you mentioned, is seen in majority of cases, and it may be related to transient narrowing of the UPG junction in the early development. And that's the reason why there is actually a hydronephrosis. And it is usually mild with less than 6 mm in the second and 8 mm in the third trimester. But if you actually take cases which are more than 10 to 12 mm, then you would like to not think too much about a transient hydronephrosis. Then, of course, when we talk about the anomalies, so when we come to the obstructive, non-obstructive anomalies, we've seen in this meta-analysis over 1,600 babies, and they saw that the most common diagnosis is the UPG obstruction, and the second is the vesico-ureteric reflux. Now we come to the most important part, that is, how do we actually assign severity to a patient, to a baby who's having dilatation? So it could be 3 criteria have been classically defined: the renal pelvic diameter, SFU criteria, and the UTD classification. And the renal pelvic diameter cutoff for the second trimester is usually 4 to 5 mm, but if it is more than 10 mm in the second and 15 mm in the third trimester, then they are at the greatest risk of anomalies of the urinary tract. The SFU, at the same time, it says that if there is no dilation, it is first 0 grade, mild, moderate dilatation, including a few calyces, and it is grade 3 if it is calyces are uniformly dilated across. And grade 4 is grade 3 plus thinning of the parenchyma. So this is what is the SFU classification, where there is major calyces are dilated. In grade 3, all calyces are uniformly dilated, and in grade 4, there is parenchymal compromise. So these are some of the images of the various grading according to the SFU, where you have uniform dilatation of calyces, then there is thinning of the renal cortex. So that's how you go about it. But the current and the most uniformly accepted, and this classification is unique because this has actually been an amalgamation of both the antenatal and the postnatal classifications, and it can continue from your antenatal period to the postnatal period. And it is based on the ultrasound findings of the calyceal dilatation, parenchymal thickness, parenchymal appearance, bladder abnormalities, and ureteral abnormality. And there we have this classification of A1 and A2 to 3. So some people might always wonder why A2 to 3 is always mixed together. And it was seen that when we actually try to classify between A2 and A3, there is not a very, a strong divide between A2 to A3. So it is not possible to differentiate antenatally. However, postnatally, it is P2 and P3 is different. So A1 is very simple till the time that it is less than 7 mm up to 27 weeks and less than 10 mm at more than 28 weeks. So we define that there is some dilation, but it is only A1. And between 2 to 3, A2 to A3 is when you have more than 7 at 27 weeks, less than 27 weeks, and more than 10 at 28 weeks. along with other findings like calyceal dilatation, ureteral dilatation, renal parenchymal or bladder abnormalities. So these are some of the A2, A3 where you go into the calyceal dilatation or more than 7 mm, the amount of dilatation is more at 21 weeks also. Now, when we compare SFU with UTD, it was seen that although both have similar prognostic ability to predict resolution, why are we trying to see? So we want to know whether this particular thing is going to resolve, whether this particular thing is going to progress. So it has been seen that although both of them have similar prognostic ability, the inter-observer agreement is higher for UTD. So we are more likely to agree that, okay, this is UTD A1, and there's much less of confusion when we follow the UTD classification. At the same time, we need to see whether it is unilateral, bilateral. Ureteric dilatation is very, very important, whether the ureter is dilated, and that would be consistent with vesico-ureteric reflux. And this is what something which we need to observe. Or there is an obstructive uropathy distal to the UPJ junction. Renal parenchyma thinning or cortical cyst needs to be seen, and echogenic renal cortex. So when we are seeing the ultrasound, we need to see all of these findings like bilateral, calyceal dilatation. All of these also need to be seen along with the thickness and trabeculation of the bladder wall and enlargement. So as a basic idea, if we want to have if the bladder is enlarged or not, so if you have a gestational age plus 2 centimeter, 2 millimeter, then you would say that, okay, this bladder seems to be enlarged or dilated. So if it is say 31 weeks, but it is 61, so you say that, okay, this is an enlarged bladder. Amniotic fluid volume. So like I would say in Dr. Asha's case, in both case 3 and case 4, we would like to know the amniotic fluid volume. So anytime amniotic fluid volume is present, so that's actually a good sign. But oligohydramnios is consistent with impaired renal function, yes, and there are actually 2 hits where the oligohydramnios can occur. In the initial part, it can occur even without a chronic renal damage. There might be a slightly reduced amniotic fluid volume, but with a progressive disease, there's the irreversible fall in the LICA volume. So this is something that's a huge thing to be seen when we are reporting renal abnormalities. Urinary ascites. So this was one of our cases which actually came with an where this patient had urinary ascites. Again, some of the measurements on ultrasound, we need to see whether there is progression, what is the fetal sagittal bladder length as mentioned earlier, whether there is elongated renal length or there is hydronephrosis. Now, interestingly, this is a recent scoring system in which they said that if you have severe megacystis, ureteral diameters on both sides are 1.3 for each millimeter of dilated ureters, or there is oligohydramnios for which you gave a score of 4, and if it's a male fetus, then this particular system can actually help differentiate lower urinary tract obstructive lesions from non-obstructive causes if your score is more than 9.5 with a good sensitivity of 78%. So these are some of the important points that can help tell you whether you are progressing, you are actually looking at an obstructive lesion or it is a reflux. Again, the further evaluation would depend on whether there are any extrarenal abnormalities, severity, unilateral, bilateral, what is the gestational age, and what is the amniotic fluid volume. So it has to be a collaborative maternal fetal team along with the involvement of a pediatric urologist who would also help in. Yes, so when we have a dilation of renal pelvis, we see if it is transient and we need to follow it up. Again, if there is pelvic calyceal dilatation with ureteral dilatation, then we have to see whether if there is no ureteral dilatation, we know that it is PUJ obstruction. But if it is ureteral dilatation, look at the bladder. If the bladder is not distended, it is probably vesico-ureteric reflux or megaureter. If the bladder is distended, then whether it is severe, then you think about a PUV or atresia. If it is moderate, then again, there is some amount of bladder distension. It is bilateral reflux. So this is a simple algorithm where we can think about what is the possible etiology behind your presentation. Now you have diagnosed it. What is the next step to be taken? Is a genetic counseling and testing required? So it should be offered if there are additional fetal anomalies, women of advanced maternal age, and women with abnormal maternal serum testing during the first or second trimester. And as Dr. Asha just presented, you have to recalculate the risk. So if there is a mild hydronephrosis or a mild urinary tract dilatation, you will have to recalculate the risk as Dr. Asha has done from the a priori risk. And then the further testing can be offered according to risk stratification. It could be your previous biochemistry is available. You have to recalculate the risk according to the previous risk and go for further testing. Are there any other genetic association? So bladder neck obstruction may be isolated or associated with coexisting fetal structural abnormalities. If there is megacystis, then moderate amount, that is 7 to 15, has higher association with chromosomal abnormality than more than 15, where it is a purely structural abnormality. Again, prune belly syndrome is associated with various chromosomal abnormality or various pathogenic CNVs. So these are the indications where you would like to prefer to go for genetic testing than other situations. Now, most importantly, we want to know what is to be done when we have a urinary tract dilatation. So mostly, as mentioned, it is a transient one. 88% would resolve. Most of the unilateral, all unilateral, most bilateral would resolve, and repeat scans is advisable. There is a very narrow window of fetal intervention that is a little controversial, but still I would mention it in the end because we are talking about something conservative and whether we should be continuing these pregnancies. So when we talk about unilateral fetal urinary tract dilatation in the second trimester, we just have to repeat a scan in the third trimester. And if it is still less than 10, then the risk is low and no further follow-up required in the antenatal and postnatal period. But if it is more than 10, then you would like to do a postnatal evaluation. Now, if it is a bilateral hydronephrosis, it is we need to follow it by serial examinations at every 2 to 3 weeks. If there is oligohydramnios, then gestation-specific management and postnatal evaluation is required. If, however, there is no oligohydramnios and the renal pelvic diameter is more than 10, then again a postnatal evaluation is required. But if it is less than 10, then no further evaluation is required. So this is a general outline for management of urinary tract dilatation. Now, I will come up to a little bit of a controversial topic, which is the in utero intervention. And I'm speaking purely because, this is something that we are looking at a conservative management. And I really recommend reading The Fetal Therapy by Mark Kilby. It's a really good document to be read in terms of fetal interventions that can be done. So when we have women with congenital bladder neck obstruction, so in a systematic review, it was found that the most important prenatal sonographic factors which predict the function are renal cortical appearance and the presence of oligohydramnios. Then the other thing that we need to understand is, before we attempt any kind of intervention, are the fetal kidneys functioning? Is there a role of fetal urine analysis? So classically, we know that we have to do a repeated vesicocentesis, because the first is the kidney, the bladder, the second one is from the upper urinary tract, and the third one is the functional analysis. And if we have concentrations which are less than 100, 90, less than 200, less than 8, less than 20, or less than 6 of all of these, sodium, chloride, osmolality, calcium, protein, then we know that, okay, these are not getting excreted and the kidneys are still functioning, so the baby is okay. But what is the evidence for urine analysis? So it was seen that in a systematic review with 572 women, most useful elements were calcium and sodium. However, none of them yielded clinically significant accuracy to predict renal function. Now, if we are actually planning a fetal intervention, we need to strictly counsel the patient, because overall outcome would depend on the etiology, chromosomal or genetic abnormality, and other associated structural abnormality. What is the gestational age of development, pulmonary development, and the degree of in utero damage. And the best candidates for fetal interventions would be fetuses with isolated congenital bladder neck obstruction, early onset oligohydramnios, reversible fetal function, and not at all to be done in fetuses showing irreversible in utero renal damage, pulmonary hyperplasia, as they already have significant risk of renal failure requiring renal replacement therapy. In the article by Ruano et al. In 2017, they have given a very nice staging system for management of congenital bladder neck obstruction, where they have looked at amniotic fluid, renal appearance, and urine analysis. Now, if all of this is favorable, then anyways, you don't need to do anything. In the stage 2, you have oligohydramnios, but normal to echogenic kidneys. And in stage 3, you have oligo and hydramnios with a bladder refilling of more than 27% 48 hours after vesicosynthesis. And this particular group is the place where you might want to do some intervention, need to refer to a fetal medicine center who have the expertise in doing this intervention. This was a small video of shunt. It is old because we have actually stopped doing it. We do shunts more for pleuroamniotic shunts for pleural effusion. So this is the Harrison's bladder shunt, and we are going inside. This is the placenta, this is the fetal bladder, and so this is, we will be going inside. Yeah, and we are indenting the fetal bladder, and once we are inside the bladder, we will push this inserter, and we can see the shunt uncoiling inside the bladder. Once the shunt is inside, we pull the plunger out so that the other part is outside in the amniotic fluid. And this is how this is being placed, and this part is inside the amniotic fluid. Now, we have the evidence against the shunting, in which Pluto said that although there was slight improvement in the survival at shunting, that it was the results need to be interpreted with caution, because there were too few cases with a lot of protocol deviation, and the postnatal normal renal function remained low irrespective of whether the shunting was done or not. And in another systematic review, which included the Pluto, there was no difference in the postnatal renal function. So shunts are essentially out, except a very, very few people where you have a small window of intervention. Again, fetal cystoscopy came in a big way, where you actually go inside the fetal bladder and do laser fulguration. It has got a lot of side effects, as you would imagine, but it actually showed that there would be a slight improvement in perinatal survival with fetal cystoscopy, and overall rates of survival with normal fetal function were slightly better. Now, if we compare fetoscopy with vesico-shunting, there is no RCT which is available, but it has been seen that the normal renal function was slightly more in the vesico-amniotic group. So this is a algorithm that when we have a suspected urinary tract obstruction and the amniotic fluid is normal, renal appearance is normal, we don't do anything. However, if there is oligohydramnios with echogenic kidney, we need to assess. We need to assess with a detailed structural scan, chromosomal abnormality, and if possible, fetal urine analysis and bladder refilling times. And if it is stage 2 or stage 3, then we need to seriously consider in a center which has adequate expertise that probably give the option to the patient. So UTD A1, just repeat one ultrasound at 32 weeks, and A2 to A3, this needs to be followed up as discussed, and postnatally it would require follow-up. How is the prognosis? If it is severe urinary tract dilatation, risk of uropathy is 88%. Similarly, if it is mild, then surgical intervention is required in 10%, but severe hydronephrosis, surgical intervention would be required in 63% of the cases. If you go by the SFU, resolution is seen in SFU2 in 70%, VUR 40% if dilatation, functional imaging would be required for SFU 3 to 4, and UTI is seen in SFU up to 23%, and end-stage renal disease in the early stages is quite rare. However, as the stages are advanced, risk becomes quite high. So I would just like to present this particular case, which had fetal urinary ascites, and she came to us as 31 weeks. So we just did the ascitic fluid tapping, which confirmed the fetal urine, and we followed her up with an LSCS at 34 weeks. After birth, cystoscopic fulguration of the PUV was done, and a scan at 7 weeks showed that one of the kidney had only mildly impaired function, and at 2 years of age, this baby was doing well. So all is not lost. And we just did a small review of our cases of there was just a few cases of around 24 cases, and we realized that 33% were diagnosed between 20 to 24 weeks. The difference, the time to referral was, between 1 to 2 weeks after diagnosis. The average dilation was somewhere between 7 to 10 in majority of the cases. And according to the stage of presentation, 16 cases presented with A2 to A3 or the severe dilation, and more than 10 in the first out of the 24, 8 had more than 10 in the second trimester, and more than 15 in the third trimester. When we talk about the outcome, we had 3 neonatal deaths, but rest of the babies at the follow-up of up to 3 to 9 months were doing all right and well. So 83.3% actually with milder dilatations, and those presentations are actually doing well. So to conclude, UTD can be diagnosed and its severity graded based on the APD of the fetal renal pelvis. If detected, it needs a further workup for rule out obstruction and renal dysplasia and extrarenal structural malformation. Outcomes depend on severity of obstruction and gestational age at diagnosis and the associated abnormality. The role of fetal intervention is for very, very selected conditions, but I would like to say that this is one of the most common diagnoses that we come across. So let us not give up on these babies. These can be managed very well. So thank you very much.
Thank you so much, ma'am. So with your permission, ma'am, shall we move to the next case?
Yes, please. Thank you.
And we'll take every question at the end of the session. Thank you so much. So after this fabulous and detailed presentation, let us move on to our next case, and let me invite Dr. Unmesh Bhosle to present his case.
Okay, thank you, sir. I'll just share my screen. Just a minute. Share screen. Okay. Okay, can you see my screen?
Yeah.
Okay. Good evening, everyone. I'm Dr. Unmesh Bhosle. Today's interesting case is binder syndrome. Is it worth terminating? First of all, I would like to thank Dr. Supriya Gadekar ma'am, Dr. Santosh Sabnis sir, and Dr. Umarji for giving me opportunity to present this case. Now moving on to the case first. This is third gravida patient with gravida first 7-year child, gravida 2 right tubal ectopic pregnancy, came for anomalous scan. So at 19 weeks, there was flattening of the nasal bridge with vertical appearance of the nasal bone. Nasal bone was normal in length. As you can see in this image, there is flattening of the nasal bridge with vertical appearance of the nasal bone. So after eyeballing, we can diagnose it as a binder facies. But there is angle which can calculate between frontal bone and nasal bone, that is called nasofrontal angle. And in this case, that was 144 degree, which was increased. So while calculating nasofrontal angle, we can draw the line along the frontal bone and nasal bone. So this is the intersection of two lines forms the angle called nasofrontal angle. These are the measurements of the nasofrontal angle, which from the 18 to 21 weeks, maximum up to 140 we can take. But in our case, that was increased, which was 144 degree. We did the 3D images. These 3D images showed there is flattening of the nasal bridge with flattening of the mid face. We can see in these 3D images. The patient came for the follow-up at 25 weeks. Nasal bone length was normal, and the angle was increased, which was 145 degree. 3D imaging was done. These images showed there is flattening of the nasal bridge. We can see in these images. Again, patient came for follow-up at 34 weeks. That time there was improvement in the facial profile, and there was not much depress or flattening of the nasal bridge. So basically, patient was not the fetus was not having any associated anomaly. Patient continued the pregnancy and at term delivered normal baby with normal face. So basically, diagnosis of binder phenotype. Uh, this is the second case. Priming gravida NT scan was normal and came for the anomaly scan. We can see there is significant flattening of nasal bridge with vertical appearance of the nasal bone. We can see there is some hypoplasia along the anterior aspect of the maxilla, and the angle was 159 degree, which is obviously increased. And we did the 3D imaging, which showed there is flattening of the mid face. We can see and this fetus was having associated with right kidney multicystic and left kidney was normal, and there was echogenic cardiac focus. Patient opted for the termination of the pregnancy. These are some of the points related to Binder syndrome or phenotype. Generally, it is called phenotype not syndrome because it basically associated with other syndromes like chondrodysplasia punctata, Stickler, or Robinow syndrome. And if isolated binder phenotype is there and without associated congenital anomaly, so we can continue pregnancy, and over the period of 7 to 8 months postnatally, there is improvement in the facial profile. So that would be good. And thank you.
Excellent, Umesh.
Thank you, sir. Yeah.
Should I move on?
Please, sir.
Yeah.
Yes, sir.
Yeah, after those two wonderful cases, just let me take you through some theoretical and some more cases of binder phenotype. Now, what is this binder phenotype? Because, this is because the name itself, the word itself is so fascinating that, yes, it is being very, very, big. I think a lot of people now talk about the binder faces. Now, this is actually a developing anomaly affecting primarily the anterior part of the maxilla and the nasal complex. It's failure of development of the, one second, let me just put into this thing. Failure of development in the premaxillary area with associated anomalies of the nasal skeleton. And primarily what you find is a flat underdeveloped midface there. Now, see, it all started with people talking about binder syndrome. Some people call it as a maxillonasal dysplasia, maxillonasal dysostosis. There is a group with a last study. They said that this is actually a mild form of chondrodysplasia punctata. That because most of them actually end up with the dentist or the orthodontist or the plastic surgeon very late in adulthood. And at that time, the primary features of the chondrodysplasia punctata are lost. And hence, they said that this is actually a form of chondrodysplasia punctata. And then people called it as nasomaxillary hypoplasia, which actually is okay. But the problem is, as Umesh said, actually it does not represent a single nosologic entity. It's a part of multiple syndromes. And actually it is a surgical entity, not syndromic. And hence, so what should we start calling it now? So binder faces or binder phenotype or a binder association actually is the right word to use here. Now, in the newborn, what are the findings that you normally see? You find an increased or absent nasofrontal angle, hypoplastic nose with a small lip. The nostrils are half moon shaped. The upper lip is convex with high arched palate. You can have mild hypertelorism. Then, of course, a malocclusion with lower overbite. That is a dental issue that is normally diagnosed. The frontal sinuses can be hypoplastic or absent. And then there are various anomalies of the cervical spine. Then hearing impairment, cleft palate, strabismus, cardiac defects and intellectual disability. So, these are the things that you see in the newborn. But, we are talking prenatally. So what are the ultrasound, findings? So, usually you pick this up in the second and the third trimester. First trimester, there is not much available, cases where people have diagnosed it in the first trimester. So even I have never seen one in the first trimester. But what catches your eye on ultrasound is a flat profile. See, taking a facial profile is a part of the protocol for every second trimester scan. And that is one view which I think everyone is trained, because that is one view which the parents actually want to see. Every time they say, doctor, kindly show us something. I would like to see the baby. So it is the facial profile that we always show them. So we are all well versed with the facial profile. We have a wonderful eyeball recognition of what a normal facial profile is. And then when you look at it, you find that the facial profile is flat. If you want to go into quantitative measurements, the nasofrontal angle is either absent or increased. You have a hypoplastic nose with a small tip, the protruding lower jaw, and then if the upper alveolus, if you go in the coronal views, you will find that normally it's where you find a well curved structure, you find a square shaped upper alveolus. And then of course 3D is something which adds up to our diagnosis that we get on 2D. Now this Umesh has already taken us through. This is from the same paper. So what actually you're doing is that if you're using a two-line technique, then you're drawing a line along the frontal bone and then along the nasal bone, and this angle is a nasofrontal angle. And as Umesh pointed out, yes, 140 degrees, because this is 143 is the maximum they had in the normal this thing. So anything more than 145 is definitely an increased nasofrontal angle, and that actually gives us some kind of a quantitative support. But otherwise, it's always a subjective. You look at it and you know that this is you flat profile, the nasofrontal angle is increased, and the lower jaw is protruding. You will find that the lower jaw is protruding. And when you go into coronal, you will find a flat nose, square shaped rather than the typical curvilinear one that you get there. And let me show you 3 cases here. This is 21 weeks, 2 days. And definitely, I don't need to make any measurement. This is a flat profile there. That's the 3D there. Call this patient at 30, was aim for the growth scan at 35 weeks. They decided to continue this pregnancy. And of course, you have the similar kind of findings that you see here. And then, of course, the 3D later on becomes much better. And you find that you have this mid-facial hypoplasia there. You have a depressed nose. Nose is nearly vertical there. And even when you look from the front view, you find that the nose is pretty flat there. So this actually, look at this, the curvature that forms because of the mid-facial hypoplasia that we encounter in binder. This is another case, similar type. You have the same findings with 3D, and one more case to show you this, and then you again have a little squarish kind of a alveolar arch there. Now, the question is, it's not very uncommon. You do see it, but then there is a variety of etiological factors, and you cannot focus on one entity. The etiology is heterogeneous, and honestly speaking, it is not yet fully understood, because every year or so you find one more article coming in where they found it associated to something else. Most of them are sporadic, and also a lot of them can be just isolated. But to call it isolated, we need to really know what are the other associations that can have a binder phenotype, so that we look for them, we investigate for them, we rule them out before we call them as isolated. Now, teratogenic factors bird trauma. The common amongst them are I'm not going to read through everything. The warfarin embryopathy and other vitamin K deficiencies is one of the common associations which has been established. Then maternal exposure to phenytoin, rubella, alcohol. There have now been cases where they felt that yes, this has been associated with maternal autoimmune disease like SLE and people on maternal anticoagulation. Then there have disorders with decreased first trimester vitamin K levels like hyperemesis gravidum, biliary lithiasis, pancreatitis, hepatic disease, and alcoholism there. And chromosomal XP22.3 deletion. But yes, whenever you see this, whenever you find that the nasal ridge is depressed and all, always rule out T21 also. I will show you a case where we can all think about. And then you have single gene disorders and chondrodysplasia punctata and its type, the Conradi-Hünermann syndrome, Kutel syndrome, Stickler syndrome, the Robinow syndrome, and infantile sialic acid storage disorders. Actually, there is a larger list to this. These are the common ones which I have put in there. So the commonest amongst these, three things that we actually really have to think about is the chondrodysplasia punctata, the warfarin embryopathy, and vitamin K deficiency. And then vitamin K deficiency can come with various other things. And that is the reason the history also becomes very, very important. So chondrodysplasia punctata. Now, again, is a condition, which is still not very well understood because of its types. And so you have the rhizomelic type 1, 2, 3, which is usually lethal in infancy. And it is it comes under the heading of skeletal dysplasias. And so you in the rhizomelic type, you have proximal bone shortening, short stature, flat faces, etc., etc. In the Conradi-Hünermann syndrome 2, which is an X-linked dominant, and then you have an X-linked recessive, the brachytelephalangic type of chondrodysplasia punctata. And the causes include chromosomal, lysosomal storage disorders, cholesterol synthesis defects, abnormal vitamin K metabolism, and also maternal autoimmune diseases. So again, this is not as simple as it looks. But for us prenatally, the starting point in most of the cases is that we see that there is a binder's faces there. And then we know that, yes, this can be associated with chondrodysplasia punctata. And hence, what we actually have to look for is, are there any premature foci of calcification, which is commonly called as stippling? So stippling is considered to be a classical word. But remember, stippling is not just restricted to chondrodysplasia punctata. It can be seen in some other syndromes also. And then you can have the premature foci of calcification, the epiphysis of the long bones. So basically, you have calcifications in the cartilage. You can have it in the vertebral column, the talus, and the calcaneus. You can find a premature ossification of the coccyx. Long bone shortening, not always. So not all types of chondrodysplasia punctata are going to show you long bone shortening. And then binder phenotype. The binder phenotype is something which you see, again, not in all the cases. So, but yes, one of the common association for a binder phenotype is chondrodysplasia punctata. This can also have associated findings, vertebral, narrowing of the spinal canal, and congenital heart disease. I'll take you through 3 cases. Now, this case, of course, the starting point was a flat facial profile. This is definitely a flat. This is as good as this angle is very, very close to 180 degrees there. And that's the 3D of that, a similar image which we saw there. And there you can see that this is 20 weeks, and you can see a premature ossification of the proximal epiphysis of the femur. The spine looked normal. There was no typical any narrowing or this thing made out. Now, this is another case. This is the classical stippling that we talk about. You have basically the punctata is you supposed to see punctate calcifications, but not necessarily that. It may start as punctate calcifications, but eventually what you see is that the cartilaginous part is ossified. And here you can see you have the proximal femoral epiphysis, and when you go down, you see the distal femoral epiphysis, which is ossified. And this is a cross section of the knee joint. Actually, the patella also had shown some classification, but the facial profile was absolutely normal. So this is not associated with a binder phenotype there. And case 3, you can see again, you are seeing the stripling of the proximal femoral epiphysis. The facial profile is borderline. It's borderline. You can't call it as a binder basis, but definitely I would have expected at 19 weeks, 5 days, a little better angle than what I was seeing. But then, this patient was lost to follow up, so really couldn't know what happened later there. Now look at this 32-year-old primey with a typical binder faces there. The nose was flat. Now, so that's why, it's just that you see something, everything else was normal. There was no premature calcifications, there is no markers, everything else was normal. But when I took the file, I realized that the Downs risk estimate in the FTS, which was done outside, was 1 in 657, which I would say is an intermediate risk. But then see, with this appearance, somewhere down the line, felt like I spoke to the patient and I said, I think we need to go ahead with an invasive procedure. They opted for that, and that turned out to be a trisomy 21. So T21, yes, we talk about unossified nasal bone and all, but even a flat nasal bone, T21 also needs to be kept in mind. And then sometimes binder, this I call as an iatrogenic, because see, you have a webinar of this kind and people talk about binder, then everybody next day onwards starts talking about binder. And then those people who do about 100 scans a day, they, one movement, and then they find that the facial profile looks to be flat and they label it as binders. I think every 3 to 4 months I get at least one case which has been labeled and they come for a second opinion. Now this actually I've created it today while I was scanning one of the patients. I just created it to show, because if you spend a little more time and if you really get a proper mid-sag, you will find that the mid-sag is absolutely normal. So we need to avoid creating a binder just because we know about binder. So be careful about that. And when you have borderline cases where this nasofrontal angle was 140.5, this is borderline, you need to follow them up. You ask them for a follow-up and see how this is progressing. Binder phenotype can have associated anomalies. We had one case where you have a classical binder phenotype, and then there was an anophthalmia on one side and a midline cleft lip associated with that. And this is again the 3D of that. You can even make out the midline cleft lip there, and you have a mid-facial hypoplasia. This is another case with a very, very flat facial profile, which was associated with, actually a mid-sag. You can see the worm is there. The CSP, very, very fat patient, very obese. The CSP was absent. And then you can make out that this was associated with agenesis of corpus callosum. So the binders is the starting point. Then you need to go about. So what should be your approach? Of course, confirm the diagnosis that yes, you may take all these measurements, the angles and everything. People like quantitative this thing, and sometimes quantification helps us in following up also. Take all long bones biometry. If your protocol just includes only the femur, no, you are going to measure all the long bones, because we know it can be, you can have bone shortening in chondrodysplasia punctata. And at the same time, when you're going to take the biometry of all the long bones, you're going to look at all the long bones. You're going to look at all the long bones. Actually, you pick up if there is any premature ossification of any epiphysis there. They do a detailed look for any associated findings. Liker, yes, quite a few of times you will find that this is associated with polyhydramnios, and then sit with the patient and take a detailed history. The detailed history is important. Ask them, about any drug intake, was she on warfarin, or look into her file. Is she a known case of SLE? So all the history again is very, very important here. And geneticist consultation. if you have a geneticist in your town, see to it that they go and meet the geneticist who can explain them all, and decide on what tests would be required based on, of course, what phenotype abnormalities that you find on ultrasound. So primarily, it's a good ultrasound that you require there, and the need for genetic testing and the place of delivery is important, because some of these babies eventually, even with an isolated binder, may have some breathing problems immediately after birth. And so delivery in a setup which has facilities of adequate care immediately postnatally is important. So what are the testings that can be done? Of course, the chromosomal microarray and gene sequencing. This is a list of all the genes that need to be looked for the chondrodysplasia punctata to then rhizomelic chondrodysplasia punctata. This is the RSA, that is for the chondrodysplasia punctata 1. I'm not reading through all this, but what I want to say is that's where the role of the geneticist comes in, where looking at all the findings that we have, looking at all the history that we have, they definitely take a much more detailed history than what we do. And I always recommend a geneticist consultation. Post-Pauline cholesterol biosynthesis, so for the Smith-Lemli-Opitz syndrome, the genes, and a postnatal X-ray for stippling, MRI for spinal canal narrowing, all those things would be necessary, that can be done. And depending on case-to-case basis, you have to decide what all is required for this patient. As far as counseling is concerned, picking up a binders is easy. Trying to rule out other things on ultrasound is easy. Counseling is the most difficult part, because it is a diagnosis with multiple differential diagnoses, and hence it carries an uncertain course and unpredictable prognosis, and hence it is difficult for the parents to comprehend. And the 3D image makes it more and more difficult. So once, if you've done a good 3D and you give them a 3D image along with that, and at the time of counseling, if you're trying to explain, you see, and looking at the face, quite a lot of them eventually start thinking in terms of termination. And when you explain to them about the cosmetic part of it, unfortunate part is most of them first, the question after a few questions they ask is whether it's a boy or a girl, and then you have to tell them that is not something you do. But then because they feel, okay, if it's a female with cosmetic problems, things would have. So times are changing, but we still feel that yes, a male with some cosmetic problems is still okay, but a female with cosmetic problems would become a more headache for parents, and that is the mindset that we need to change. Inform them that it could just be a normal variant, but can also be associated with other conditions, and the need for genetic testing that needs to be discussed with them. The need to meet a geneticist also should be discussed with them. And if detailed history is negative and no ultrasound evidence of chondrodysplasia punctata or other anomalies, the prognosis is favorable, and that is what you can tell them. But also inform them that some babies may have breathing difficulties, even if it's an isolated binders, may require hospitalization, and then depending on the postnatal development, the need for cosmetic surgery would be may come in, and all these things need to be told to them. Thank you very much, and thank you Pune chapter for having me here, and Unmesh for starting off on a good note, and looking forward to a few more wonderful events coming over from the Pune chapter.
Thank you so much, President-elect, and for always hand-holding.
Hello.
Chinmay, we cannot hear you.
Chinmay, we cannot hear you. Yeah.
Hello,
Yeah.
am I audible now?
Now we can hear you. Yeah.
I'm just saying thanks, Vimal sir, President-elect, who always handholds us, and it was such a fascinating presentation to see a topic like binder, which could be so perplexing and confusing for counseling. You made it so simpler to understand for us. With your permission, sir, can we move on to the next case and come back for the questions at the end of the session? We have lots of questions.
There is a trade partner video in between. Vishal?
Yes, yes, sir.
Yeah, we can go to the next case.
So you
Sanjay, you
can
can
start.
share your screen.
Good evening, everyone.
Need to go to full screen mode, Dr. Sanjeev. Yeah.
Good evening, everyone. First, I would like to thank Society of Fetal Medicine Pune chapter for providing me this opportunity to present a case at this platform. Today, I'm going to present a case of Ductus Venosus agenesis. Firstly, I would like to thank Dr. Chinmay Umarji sir for providing me with this case, and Dr. Yogesh Chaudhary sir for giving me this beautiful images. So here, a 29-year-old primary gravida patient, non-consanguineous couple. Her NT scan was done at a CRL of 43 mm. Double marker was done with Prisker software, which was low risk. Anomaly scan was done at 19 weeks, which was reported as normal. Patient came to us at 26 weeks, which revealed abnormal biometry. Abdominal circumference was on 5th percentile and effective fetal weight was on 2nd percentile, suggestive of early onset fetal growth restriction. Here we can see in the graph that AC was on 5th percentile. Coming to the anatomy, these are the loops showing the axial section of fetal abdomen. Here we can see that umbilical vein is coursing straight and it is directly draining into the IVC. Color Doppler images in the sagittal sections revealed abnormal course of the umbilical vein draining directly into the IVC with non-visualization of ductus venosus. Here we can see the abnormal course of umbilical vein directly draining into the inferior vena cava. In heart view, the four-chamber view appeared grossly normal. However, there was slightly right heart dominance. Other structures, LVOT, RVOT, and three-vessel view were, however, normal. There was no other major anomaly in rest of the fetal structures. The power Doppler at the level of the IVC draining into the umbilical vein draining into the IVC showed the triphasic waveform of the IVC, which was different from the ductus venosus. Here I have given the ductus venosus typical waveform, which shows the normal triphasic waveform with the S wave, D wave, and the atrial contraction phase, which should be positive in the normal cases. The differentiating point from IVC waveform, there is forward flow in the A wave throughout the cardiac cycle. Follow-up for this case, amniocentesis was performed for this patient in view of agenesis of ductus venosus, as it could be associated with aneuploidies and other genetic problems. Also, there was early onset FGR and suboptimal NT, as it was performed below 45 mm of CRN. Microarray reports, however, came out as normal. In view of slight right heart dominance, pediatric cardiologist opinion was also taken. However, he also said heart was otherwise normal. So patient was reassured. Outcome, patient went into spontaneous labor at 28 weeks, delivered 850 grams baby, which however could not survive. We have follow-up for second pregnancy also for this patient. Patient shortly came for her second pregnancy. In the second pregnancy, NT scan, EFTS were low risk for aneuploidies. But however, there was high risk for FGR. This time, ductus venosus looked normal. Anomaly scan was done at around 19 weeks, which revealed again abdominal circumference on 5th percentile. There was associated echogenic intracardiac focus and normal ductus venosus. This time also, patient was offered amniocentesis in view of early onset FGR and EIF. It came out normal. Outcome, patient recently delivered 2.3 kg male baby at 36 weeks. So take home message from this case, we should carefully see the fetal umbilical portal systemic system during each scan, and we should follow the FMF protocol for ductus venosus. I would like to tell some points about ductus venosus examination. Ductus venosus should be examined during fetal quiescence firstly, then magnification should be proper. The image should occupy the fetal thorax and abdomen only. We should take a para-mid-sagittal section of the fetal trunk. Pulse Doppler volume, sample volume should be small. It should be around 0.5 to 1 mm. Then insonation angle should be less than 30 degree. Filter should be set at a low frequency. Here we can see the positive A wave in the normal ductus venosus waveform and the reversal of A wave in the abnormal cases. Second take-home message is these shunts are associated with FGR, associated anomalies and aneuploidies. Here we can see the chart from the Achiron et al. UOG 2016. The different associations have been observed like FGR, aneuploidies, different anomalies in the different types of shunts, which I think Dr. Bijoy sir will cover in his topic. These are my references. Thank you.
Thank you, Dr. Sanchita. Shall I carry on?
Please, sir. Thank you.
So let me just share my screen. I hope my screen is visible. Yes.
Clearly, sir.
Yes. Thank you, Dr. Sanchita, for your case. And in fact, DV is agenesis is a common problem, and it's tragic that the baby died after birth. But I think after going through this presentation, you will understand why that happened. Now, DV is a particular vessel that's like a superhero that is not seen. It just does its work and then goes back into darkness, and nobody actually thinks about it. And for me, DV is actually a superhero, because when you look at the DV, that's the vessel that you go for when you want to screen for aneuploidies, when you want to screen for congenital heart disease, when you want to make management decisions in fetal growth restriction, and also when you want to make a diagnosis in arrhythmia. So look at this. This is what fetal medicine is about: aneuploidy, heart disease, growth restriction, and that's about 90% of what fetal medicine is. And there is one vessel that you would look at, and that's the DV. But unfortunately, after birth, that remains as a mere footnote in the history of the life of that person, because once you cut the umbilical cord, the DV regresses, disappears, and there is nothing else to talk about it. But in the antenatal life, when you find that the DV is absent, it's going to create a lot of questions, and we are not sure as to how to approach this problem. But before I address that problem, we should understand that the DV is an anatomical paradox. Because when we look at the DV, we always believe that it enters into the right atrium, because that's how it's anatomically placed. But when you look at the DV, it's actually a straight branch of the left portal vein. And if you draw a straight line across the umbilical vein, across the left portal vein, you would find that it lands up directly in front of the DV. So it's a straight line of purely oxygenated blood that comes from the umbilical vein and goes into the ductus venosus. And it's also important to know that the ductus venosus decreases in size, and that decrease in size is important to increase its velocity from a mere 15 centimeters per second in the umbilical vein to as high as 75 centimeters per second inside the ductus. And the angle is important, because when you look at the angle with which it enters the right atrium, it hits the floor of the right atrium, while the blood coming from the IVC goes into the chamber of the right atrium. So it's sort of a vascular crossover where the DV comes in and hits the floor of the right atrium, whereas the IVC takes blood and goes into the chamber proper. And that's where I use this concept of the trapdoor effect. because as soon as the blood enters into the right atrium, it falls through the trapdoor that is present on the right atrium, that is the foramen veil, and there it jumps down into the left atrium, and that's its final destination. The DV appears to enter in the right atrium, goes through the trapdoor of the foramen veil, enters the left atrium, and gives purely oxygenated blood to the heart and the brain, the most vital organs that you want to preserve. But the amount of blood that goes through the ductus venosus is not that large. Only 25% of the entire blood that enters into the umbilical vein finds its way to the left atrium. The rest, the majority of that, goes into the left lobe of the liver. And that's why when you have a shunt between the left portal vein and the systemic veins, it is the left lobe of the liver that is going to be deprived of its oxygenation, of its nutrition, and that's why the liver decreases in size, and that's why you get growth restriction whenever there is a problem with the portal system. And therefore, you have to remember that the volume of blood that reaches through the DV is less, and therefore its absence is not going to create a huge difference unless there is volume overload. And also it's important to remember that there is a thing called as the breathing paradox. Now, in late onset growth restriction, when we see breathing movement, we are reassured that there is no acidosis, there is no hypoxia, and therefore we are reassured that this baby is going to do well. But as the baby breathes, it increases the pressure within the DV and increases the PI of the DV flow. And as a result, if you look at the DV while the baby is breathing, you can get a high DV PI, which can actually make you think of acidosis when actually this baby is doing pretty well. Now, having said that, since we know that DV actually enters into the LA and it takes only 25 to 30% of the preload into the heart, what happens when the DV is absent? When the DV is absent, the first question you have to ask yourself is, how is the blood reaching the heart? How does the blood coming from the umbilical vein reach the heart? And for that, you have to go through a series of steps to reach your final diagnosis. And the first step, as with any variation that you would find in anatomy, is to rule out other structural malformations. And when you talk about DV, the most common malformation that you're going to suspect here is a heterotaxy or Noonan syndrome, or sometimes they may be associated with a single umbilical artery. The second thing that you need to do is you have to look at the heart to see for signs of volume overload. Is there increased size of a heart, or is there tricuspid regurgitation? All signs of increased volume overload if the entire blood that enters into the umbilical vein comes directly into the heart. The next question would be, is there aneuploidy? Now here in this particular case, if you find that the DV agenesis is isolated, which means that there is nothing else on the baby, there I would suggest that you do a microarray. But if you find that there is DV agenesis along with number of other abnormalities, that means you're looking at a more severe karyotypic abnormality that can be picked up on your conventional karyotype. Now, once you have ruled all those things out, no structural malformations, no karyotypic abnormalities, then you come to step 3. Where is the umbilical vein? Is it entering into the liver or is it outside the liver? If it is extrahepatic, then you have to ask yourself, where is this umbilical vein ending? Is it ending in the heart directly, or is it going into one of the systemic veins? Now, if it's entering into the heart, as you can see in this case, you would find that there is going to be obvious volume overload. There is going to be a large heart with all the signs of developing hydrops. You're going to get cardiac overload because now it's not just 20 to 30% that is coming into the heart. The entire blood from the placenta is going to come into the heart. And so in these cases, you're going to get DV agenesis, and you will find that the UV is draining directly into the heart, as in this case, in the right atrium. There will be volume overload, there will be cardiomegaly, and the portal system will not be present because the umbilical vein is bypassing the liver. It can also enter into the systemic veins. Now, in this picture, the first thing that is going to strike you is that the IVC is pretty big. And if you look at the sagittal section, you would find that the umbilical vein is ending directly into the IVC, similar to the case that you saw that was presented by the previous speaker. Now, once you see that it is entering into the IVC, you know that there is a possibility that the portal system is going to be completely absent, because as you can see, the point of entry where the umbilical vein enters into the IVC, flow is smooth and flow is going to go directly into the IVC with no development of the portal system. It can also enter into the iliac veins. As you can see here, it's going down, entering into the iliac veins, and then entering into the IVC. Now, these are all extrahepatic causes of the umbilical vein. But what if it is intrahepatic? Now, here you can see on your screen, on the upper side, you have the left side, and the lower side is the right side. I can see the vessel, the umbilical vein, entering into the liver, but I can't see it going anywhere else. Is it going to the left? Is it going to the right? I'm not sure. I can see the gallbladder, and that gallbladder tells me that the umbilical vein that I'm looking at is the left umbilical vein. I switch on color, and on switching on color, I can see that that vessel that's entering into the liver is actually branching. It's branching, it's giving off branches to the left lobe of the liver, but still I cannot see the right portal vein. And on doing a sagittal section, I can see this. And this is a very rare finding, where you find the umbilical vein is actually ending in one of the hepatic veins, creating an umbilicohepatic shunt. And because of this shunt, blood is now being shunted through the liver into the hepatic veins, creating this sort of a passage. It can also enter blindly into the liver. As you can see in this case, the umbilical vein is ending into the liver. There is no connection with the hepatic veins, and there is no ductus venosus. Now, this is different from the previous case in the sense that here the blood that is coming through the umbilical vein is going to go into the portal system, and through the portal system, through the hepatic sinusoids, it is going to go into the heart, and therefore it is called as an umbilicoportal hepatic shunt. The difference between the previous case was that in the previous case, the right portal vein was completely absent, whereas in this case, both the left and the right portal vein is going to be present. Now, if you find that the DV is absent, if you find that the umbilical vein is ending directly into the liver, and there is no other problem that you can find, the next thing you need to look for is shunts. Because if there is a shunt present between the left portal vein and the hepatic veins, what is going to happen? Blood is going to be diverted away from the ductus venosus, and when blood gets diverted away from the ductus venosus can disappear, and those are conditions where the DV is going to disappear later on. It's an acquired condition, and this is how it will look like. You can see a red shunt flow going across the left portal vein into the hepatic vein. This is a small shunt, and in this case, the DV was not absent. But if the shunt is large enough, it is going to take away blood from the ductus venosus, and the ductus venosus can disappear. Now, these are conditions that can happen post-infections, post-thromboembolic events, and whenever you find an echogenic spot in the liver, most of the times we think about aneuploidy, we think about infections, but we should also think about the possibility of a developing shunt between the left portal vein and the systemic veins, that is the hepatic veins. Now, once you have done all that, you have looked at the DV is absent, you could not find any shunt, the umbilical vein is entering into the liver, or it is entering into one of these locations that I talked about, then the next most important thing is to find out if the portal system is present or absent. And that's where we come to the previous case that was discussed. Was the portal system present or absent in that case? Now, when the portal system is absent, what will happen to the fetus? There is no method by which blood can actually reach the liver, because the main supply to the liver, which is the portal system, is going to be completely absent. Now, there is a very important and simple clue that will allow you to know whether the portal system is present or absent, and that is to look for aliasing. You look for aliasing at the point of entry of the umbilical vein into the systemic venous flow. And here I'm showing you two cases, one on the left side where you can see the umbilical vein is ending into the IVC, there is no aliasing. But on the right side, you can see that there is aliasing at the tip as it enters into the IVC. And if you look at the spectral wave pattern in this case, you will find that it is exactly similar to that of the ductus venosus, unlike in the case on the left-hand side, where you will find a venous flow similar to that of the IVC. And if you remember the case that I showed you before, the umbilical hepatic shunt, there also you can see aliasing at the point of entry into the hepatic veins, and that's why the left portal venous system is completely developed in that case, and therefore the outcomes are good. The biggest question that most of the people ask me here is, this vessel looks like the ductus. It has a waveform like the ductus. So is it the ductus? Now, it is not the ductus because the term ductus venosus is used only for that vessel that connects the portal sinus to the venous vestibule. It's unique, it's special, and it's irreplaceable. And that's the ductus because it takes blood into the left atrium and provides purely oxygenated blood to the heart and the brain, and it is irreplaceable. But when it changes its location, it actually changes the hemodynamics of the heart, but that constriction helps. And that constriction helps by increasing the pressure within the umbilical venous system, thereby causing the collaterals to develop and leading to an intact hepatic portal venous system. So the importance here is that if the portal system is intact, that baby can survive. But if it is absent, the child can go into liver failure and the child will die soon after birth. So let's put all that together. Whenever you find DV agenesis, the first thing that you need to do is look for chromosomal abnormalities, rule out structural abnormalities. And it's obvious that any of these things are present, your outcomes are going to be bad. Look for cardiac overload. If there is cardiac overload, you're going to suspect that there is a possibility of hydrops developing later on. But once these things are not present, then your prognosis depends upon whether the umbilical vein is coursing through the liver or whether it's outside the liver. Is there a large shunt present between the left portal vein and the right and the hepatic venous system? Is the portal venous system intact or not? And that is where the crux of your diagnosis rests. I have just talked about DV agenesis and what to do once you pick up DV agenesis. Actually, there is a lot more, and there is a lot more to look at in the portal system. And if you're interested, I would invite you all to this webinar, What's the Color of My X, on the 14th of November. But I'm going to put forward a screening system wherein you will have 3 steps by which you can look at the intactness of the entire portal system. Hope to see you there. Thank you. Thank you for listening.
Thank you so much, Dr. Vijay. This was so fascinating to see and learn. May I request Ashok Khurana sir to give his expert comments. He's been kind and been here to guide us. Sir?
Well, I don't think there's much expert commentary left on this. We've had 3 absolutely fabulous sessions with 3 absolutely fabulous inputs. And I think all that's really left is questions. I am absolutely amazed at where our own members and our participants have put the Society of Fetal Medicine today. And congratulations to Greater Pune for making all this happen. Really, I have enjoyed learning so much this evening that I have really no expert comments to offer. This was a fabulous session and so much to learn. All the best.
Thank you, sir. And thanks to the great lectures by Aparna Sharma ma'am, Bimal Sami sir, President-elect, and Vijay sir. With your consent, sir, shall we move on to the question and answer session? So I hope I'm audible.
Yes, you are.
Yeah, thank you. So first session was, of course, lower urinary tract dilatation, and we have lots and lots of questions there. Not surprisingly, because we get so many cases every day. So, Dr. Sanchita, question to you is how to diagnose renal pelvic dilatation in different trimesters, first, second, and third.
We should follow the FMF criteria for renal pelvic dilatation measurement. In the first trimester, it should be more than 4 mm. There is categorization for that from mild, moderate, severe. 4 to 7 mm in the first trimester, then 7 to 10 in second trimester, and more than 10 in the third trimester.
Right. So once you diagnose dilatation, you would of course classify it. But as you rightly suggested, use of nomograms would be useful. So there are nomograms embedded in all the software systems, and you can use them. Many times your machine software, ultrasound machine software may also have a nomogram. So yes, thank you for that. Dr. Asha, what is the significance of ureteric peristalsis if you see renal pelvic dilatation, and also significance of bladder dilatation, which Aparna ma'am actually explained very much in detail, but just to revise. Dr. Asha, are you there?
You have to unmute yourself.
You do, yeah.
Yes, I would actually ask Aparna ma'am only to take that question because she has explained it in such a detail that I will not be able to do justice to the question. So Aparna ma'am, if you could answer that, it would be really good.
Yeah, thank you. Thank you for the question. So I think we need to have like a simple understanding that, there are actually three parts to the UTDs. So one is the kidney, one is the ureter, one is the bladder. And depending on where the dilatation is, we can at least try and pinpoint where the problem is. So first of all, we look at the kidneys. If there is renal dilatation, and if it is only the pelvis or the calyces. So that's your first level that you see. Then you come to the ureter. Now, suppose if there is only renal dilatation without the ureteric dilatation, so it's like the common sense that, okay, the obstruction is above the ureter and there is no ureteral dilatation. But if suppose there is ureteral dilatation, then it's somewhere the obstruction is below the ureter, right? So that is when we should start thinking about the reflux, vesico-ureteric reflux. So if there is ureteral dilatation, then we need to think about two things, that the obstruction is below the level of UPJ, the uretropelvic junction. So that means now the obstruction has come down. So here I'm talking about the obstruction from above below. And we have seen that one of the most common causes of obstruction diagnosed in the antenatal period is the UPJ obstruction. So yes, so first thing is whether you have only a renal dilatation or if you have a ureteric dilatation. Now, if you actually go beyond the ureteric dilatation and see if there is bladder distension. Now, bladder distension, as we discussed, there are nomograms, but yes, if it is +2 for a gestation, you have a general idea that, okay, there is some distension of the bladder. Now, if there is distension of bladder, we should expect that the obstruction is distal to the bladder. So then we have to start thinking about the PUV or the urethral atresia in females, or even one of those prune belly, and somewhere the bladder neck obstruction is now happening. So if there is bladder dilatation with ureteric dilatation, then you also have to think about if it is bilateral reflux also along with PUV. So it is just common sense that depending on the level of obstruction, you can think whether it's an obstructive UTD or it is a non-obstructive UTD. So, but the important thing is, if you have ureteral dilatation, please think about reflux above and beyond the PUV or obstructive lesions. So reflux is something that we need to think about if there is ureteral dilatation.
Thank you so much, ma'am. It was so clear. Ma'am, and would it be safe enough to say now that with the emerged evidence, the role of surgery for luto is out of the window? You would not operate on that?
Yes, mostly no. But as I mentioned, people will never give it away. I think never say. And you always see patients who are desperate, and we really want to do something for them. So yes, and if you actually look at those numbers, they're not really convincingly large in any of them. Even in the systematic reviews, when they have compared cystoscopy with shunt, so one has 34 patients, one has 35 patients. So yes, but diehard fans of surgery, I mean, probably, but no. I mean, for all practical purposes, I would say that the outcome in terms of how the postnatal renal function is going to be, ESRD, progression, all of this may not be improved. So, but one thing that we need to really look into it is the Liker. If the Liker is good, mostly the babies do well. The Liker is not good, less than 24 weeks, even think of terminating the pregnancy.
Exactly, just to elaborate on ma'am's point, we are probably Pandora's box for genetics and anomalies, and we have excellent centers like AIMS and SEMA where patients can maybe opt for really cost zero for these surgeries. So if these centers start recruiting for trials, maybe all of us should try and support and see if bigger numbers and better numbers could be generated for this.
Yeah.
Thank you, ma'am. Just to also involve Dr. Bijoy in this conversation, so about renal viability. So you see a luto and you're not sure whether these kidneys are functioning or not. Are there any tests you would like to offer for functioning of kidneys?
Well,
Would you like to do?
as already Aparna has mentioned in Mark Kilby's paper, they have found that there is no use of looking at urinary analytes. But I would disagree on the surgery part, because I would definitely want to do something for a fetus. The reason why we fail or miss out in cases of lower urinary tract obstruction is because we are not able to make the diagnosis of the cause. In the paper which compared the outcomes, they tried to look at distinctions, and when there was a urethral stenosis or when there was a posterior urethral valve, the cystoscopy group with fulguration did do well. It was the urethral atresia group that did not do well. And the cases which used a diode laser did not do well because they created a fistula right across, whereas in the Nd:YAG laser, the formation of a fistula was lesser. But what I think is very promising is the ability to put in a shunt at 16 weeks with the help of the Somatex shunt, which is a 18 gauge needle which goes into the bladder and puts in an angioplast sort of a catheter that goes into the bladder. And that can be done as early as 16 weeks. So if you find a posterior urethral valve or a urinary tract dilatation, and if you can go in that early with a needling technique like this, I think it could revolutionize the way we are looking at it. But again, the problem is at that point, we will not be able to say whether it is urethral atresia or something else. But at least we will be able to reach a point where we will be able to maybe help the patient. So I think intervention will always be there, because no matter what the outcomes are, we're going to keep on trying till we find that perfect solution. And that's how we have solved so many problems, right from transfusions to shunts within the thorax to fetoscopy. It's only a question of finding the right answer, and maybe we will.
Great. So both the fetal surgeons feel that surgery will be the way forward for this problem. So thanks for your inputs on this. Ma'am, to conclude, people are probably quite confused about classification A1, A2, and A3. You had so beautiful slides. So would you like to just kind of revise it for us?
So I think yeah, when you actually go through the various systems, you might just kind of get confused. But yes, I would say that, for now, just keep one system ready with you. UTD is a good one. And, less than 27 weeks, less than 28 weeks. Okay. If it is more than 7, okay. And if it is more than 28 weeks, right. And it is more than 10. So this is something that we can remember. It is easy to remember. And it is just 2 numbers if you remember. That is enough for you, for each one of us, because, a lot of numbers. So something like between 4 to 7, it is considered in the second trimester to be mild. But if it is more than 7, less than 27 weeks, it will automatically be a thing that you need to follow up. So just remember 2 numbers, 7 and 10, less than 28 and more than 28. I think that will solve the problem.
Thank you. Thanks a lot. So moving on to our next interesting case, which was presented by Dr. Bhosle. Dr. Bhosle, can I ask you what are the current terminologies which you would recommend when it comes to Binder's syndrome?
Actually, as Sahani sir told, basically we can call it as a binder phenotype. So that's what I feel, because it is associated with so many syndromes. So binder phenotype is correct terminology, what I think. More Dr. Sahani sir can add in this.
Sahani sir?
Yeah.
If you would like to elaborate on that.
Binder faces is good enough. Binder phenotype is also good enough. If you want to be more this thing, you can also call it as binder association. But I think binder syndrome and all we need to give up.
Yes, sir. So, and there is this very interesting question which says that liability of a sonologist in case of missed facial dysmorphism, because many times it could be subtle. What's your opinion on that?
You are a better man to answer that. You're more connected with the law than I am. I think it's liability for subtle findings. It would actually depend on the person the judge who's looking at it, but I think we can definitely defend that when there are subtle, because we all know that subtle dysmorphic features are difficult to pick up, especially in the second trimester. Maybe later on you may find it, but
Yes.
yeah, we should try to. And then see, the problem with subtle, what happens is subtle features we are scared of reporting also. We don't want to put it on paper thinking that, because now once I say this, how this will go about. So, but I feel subtle findings also should be documented. The patient should be told about them, that yes, this does not look to be very severe, but then I'm finding something, I need to follow this up.
True.
I think if we don't document that, we are missing out on something. Khurana sir is here to answer this.
Exactly. I was about to. So also an extension to this question, I think these days all us, especially the budding sonographers, we are scared about medical legal suits, and we feel that this is going to haunt us for next 21 years if I miss something out. And I think out of this fear came the measurements of facial angles and everything really. So people try to eyeball, then they go objective, and then they again say, no, subjective is better. So how this evolution has been and what are the learning points and how we can safeguard ourselves as budding sonographers?
Yeah. So first of all, we'll have to not call ourselves sonographers because those are technicians. So anyone who has an MBBS degree automatically becomes a sonologist. Point number one. Point number two, never be fearful of the law. The law will always, in a country like ours, be against doctors for a few years. We've got to learn to live with that and make sure you have a good insurance. That would look after most of our problems. The third point, I have to pick up my recharge battery. Give me a second.
Sure, sir.
Yeah, the third point to remember is that when we are writing our reports, anything that we observe should be mentioned very clearly. And then we can mention that in the report and we can discuss it in the conclusion. More importantly, because we now have several protocols available from all over the world on which protocol we are using, you just decide what you're going to be promising to the patient and prominently display it in your report. So it's not that we are guaranteeing that we're seeing everything about the face. We're certainly not guaranteeing any such thing. What we are definitely saying is that I followed the ISUOG protocol, or I followed the AIUM protocol, or I followed the FMF protocol. And each one of these has a different level of, if I may use the word, sophistication. So if you mention that there, it becomes a straightforward statement. We know that the judges are never going to be in favor of doctors for a long, long time. So that, like I said, we have to look after with our insurance. And this concept of the evolving anomalies is now so clear. All we need is a few editorials and a few journal articles, and we're going to be sorted out with that pretty much. So I think if we use our own Journal of Fetal Medicine to start publishing articles on how much can be missed, and there are a couple of editorials thrown in, we can always quote that in a court of law. That's all that is really required. And it's as simple as that. We can also say that, look, the government does not promise a reevaluation of the face at 24 weeks. So what is the government really trying to prove by having such courts of law? After all, if the only scan you're allowed is at 20 weeks of gestation, that's what the Ministry of Health and Family Welfare Directive says, one anomaly scan at 20 weeks, then you have no liability after that for an evolving anomaly. So all we have to do is to highlight these in articles in 2021, 2022, and we're completely sorted. So we just don't have to be worried at all. You just practice as you think is correct and make sure you attend all the SFM webinars. You really don't need any more education. You're getting the best in the world.
And also the consent.
Sure.
Thank you so much. So that really helps. And then coming back to the face, Sani sir, there have been questions about choanal atrasia, counseling for isolated findings, and also some questions about coccygeal calcification, how to look for it. So would you kind of like to give us a brief recap of that? You have beautifully explained all of that in your talk.
and better make out in a coronal view, in a coronal view of the spine. And because see, a coccyx is not going to be calcified prenatally, it calcifies postnatally. So that is easy. Conal atresia, I'm not good with. I've never seen one in my life. Yeah, I'm a lesser mortal, so maybe Bijoy, if he's seen a conal atresia, but people have talked about it, and they look for it, and I've never been able to do that, so I won't be able to put any information on that. But yes, when we talk about it, it is means there are case studies on prenatal diagnosis of conal atresia.
Dr. Balkrishnan, would you like to?
I am an even lesser mortal than sir. So there's no way I'm going to pick up something like conal atresia. The only video that I've seen is by Rebi Chavi only. I think everyone must have seen that video where he shows fluid entering into one side of the nostril and not the other. So I mean that's the only one I have seen. That's all. Nothing to give further on that.
Aparna ma'am, would you?
I don't even exist in this particular matter.
So in other words, I think all of us can conveniently forget about corneal atresia and just move on. Counseling is always a difficult ball game in both these cases. So, Bimal sir, how would you counsel your binders as an isolated findings? You have already told most of it. Would you like your geneticists to do most of the counseling, or how do you do that? And also, if you feel it is isolated binders and otherwise they are okay, and say facial features of the parents are also similar, would your counseling differ?
Maybe. I think we would do the primary counseling for sure. I think we need to do the primary, because even if you're sending them to a geneticist, you've got to tell them something. And telling them something is got to have some scientific substance to that. It's just not that key, okay, yeah, there is a problem, now you go to someone else for that. So that is not the way we go about it. We're going to counsel them. I'm going to tell them about the phenotype, basically. I'm going to tell them what is the problem that I'm seeing. And I'll tell them that what can all be the associations. Then I will also tell them for these associations, there are certain genetic tests that will be required. And if it is an isolated finding, even then if I'm sending them to a geneticist, I will reassure them saying that yes, most of these babies are going to do well, because you can sometimes take out images from the net and keep it with you and show them, yes, because if you go to a facial-maxillary surgeon's clinic, normally he has a lot of those images put there, pre-operative and post-operative ones. So but I think, and it's important. See, that's what I'm saying. Like sir said, you can't be scared. You should not be scared, definitely. See, if you are driving a car, you may have an accident. That doesn't mean that we stop driving. So we're going to work. But at the same time, the times have come where it is better to involve the patient in everything, rather than, with the feeling that no, now what, they will go into a state of shock. And there are times when patients come and tell us, 4 days back, when in the last 4 nights I have not been sleeping, itna ghabra diya humko, and all that, no problem. Ghabarte hain, to no problem. But that's why counseling is an art. So you have to do it in a compassionate manner. You just cannot do it standing for a minute and say that this is it, look at the photo, this is the kind of face. No, you make them say, tell them. These days it's become very important. The moment you see something like a binder, first thing you come out and make the patient stand a little away and tell her to remove the mask. Call her husband, tell her, because you're not seeing their faces at all. So you take a look at them, you tell them this, ask them the history, ask them, has anybody else, because there is an hereditary aspect to that also. There are case reports where they have said that the mother and daughter had the same kind of a thing. So counseling is something which is important, and it also should give the information. So the times have come that we are not, it is not directed, I always say that, this lady who used to come on Doordarshan to say, to tell news, she used to have a blank face. The best thing that has happened to the country or the worst thing that has happened to the country, she used to speak with the same tone. The anchors these days, they show those kind of excitement if something happy. They show a very, very sad face when. But I think we should learn from that DD news readers, where you just have to be very, very blank about it and explain things nicely to them.
Thank you, sir. So I'll direct the last question about binders to Vijay, sir. So would you like to do an invasive testing on these isolated binders, sir? And which would be your test of choice?
Yes, I would do invasive testing, because the problem with binders is that it's not karyotype. I'm actually surprised that Vimal sir got a Down syndrome in binders. It's usually, I'm surprised with that, because most of the times when you get a verticalized nasal bone like that, I'm worried about single gene disorders, which is very difficult for us to pick unless we do an exome sequencing. And so what I normally do is I counsel them that this could be a normal variant as well, but there are a host of autosomal recessive and X-linked recessive disorders that could be possible. And if the only method to pick that would be to do in gene sequencing with an amniotic fluid testing. So yes, we will do amniotic fluid testing. We'll do the basic routine karyotype, because anyway we are taking out fluid. But I would definitely suggest to do the entire gamut of testing if you want to be absolutely sure. Otherwise, it becomes extremely difficult, because binders can hit you very bad if it is one of those single gene disorders.
Absolutely. Thank you, sir.
One experience in life, you never think of T21 when it comes to flat faces like that. And then that's why I said always rule that out, because even if you're doing a procedure, rule that out, because that's been my experience with that.
Absolutely.
This is an interesting question. So presence or absence of portal system in absent DV, would that have different genetic associations?
Well, actually, it's the one in which the portal system is always intact. That is, when you have a DV-SS shunt, that is where the association with Down syndrome has actually been proven. But the case series is quite small for us to derive any definitive conclusion. It's always important to do chromosomal testing, whether the portal system is present or absent. And I would suggest, as I told in my talk, if it's isolated, I would definitely do a microarray than a routine karyotype. Because the study that Ekron's paper of 2016, they have done just a karyotype, and their numbers were not that large to say that yes, Down syndrome is more common in one particular group. But I think I would go in for an array, irrespective of whether the portal system is intact or absent.
Right. Thank you so much, sir. On DV, we do not have as many questions, because probably everybody feels it is so complicated. And portal system.
Can I
Yes, sir.
ask Vijay something? Vijay, in that same paper, the one what both of us used to call as pseudoductus.
Pseudoductus, yes.
Yeah. Now, in that same paper, he has classified it as a umbilico DV systemic.
Yes. Yes.
So that is, I think, the last classification which actually has come up from a good center. So,
Yes.
Do we still stick to this being just a constriction, a pseudoductus, rather than DV as such?
The idea of using the terminology DVSS is basically to tell us that there is a constriction there at the point of entry. But actually, the anatomical vessel DV has to have that connection which we talked about, portal sinus to the venous vestibule. So what they have hypothesized is that the entire unit, that is the umbilical vein, portal vein, DV unit, the entire unit moves across and then joins somewhere else, which is not wrong actually. It's like, it doesn't matter what you call it. The importance is what its clinical implication is. So some people call it ductus, and that's Ekron's group, and that's why they call it the DVSS. But the argument against that is it's not the ductus, it's the umbilical vein, because the ductus, as the name suggests, is a ductus venosus. It's a channel that takes in blood into the venous vestibule, and that's where the name ductus venosus is there. So, and it's a specific channel that has a specific function, and that's why it's unique. But yes, there is no harm in calling it that, because what we need to understand is that if there is constriction, the portal system is intact, always. That's all we need to know. It doesn't matter what we call it. And yes, pseudoductus is something we like and we have created. So yeah, it sounds good.
And so there is this last question which says, what nomograms to use for ductus venosus between 11 and 14?
Nomograms for what? I didn't get that.
I think they're talking about ductus venosus PIs, pulsatility index.
No, I mean, you have to look at absence or reversal of the A wave. Not going to look at the PI. To get the proper PI in the second and third trimester itself is a Herculean task. And if you want to try to look at the PI in the first trimester, good luck with that.
Thank you, sir. Thanks a lot. So I think it's time now to conclude this phenomenal session. Dr. Sabnis, would you like to ask a vote of thanks? And
fantastic session, and we were dazzled by the speakers and the expert comments. And Chinmay, you conducted the question answer session very well, and you brought out the hidden gems. And it's always a pleasure listening to great stalwarts, and it's very inspiring for all of us. And I'm sure we'll, with all the guidance of all the gurus, and we'll definitely scale new heights. And in coming days, in coming years, all the gurus will be very proud of all of us trying to better ourselves. And I thank all the dignitaries and all the participants. Thank you for the excellent webinar, and I'm sure we'll continue with this such excellent academic treats in the future as well. And wish you all a very happy Diwali in advance, and see you soon. Thank you very much. Yeah. Shall we conclude then, Chinmay?
yes, sir. Thank you so much. Thanks, everyone. Thanks for being here.
Good night.
Thank you.
Thank you.
Thanks,
Thank you.
Vishal.
Good night. Yeah.
Good
Thanks a lot, Vishal.
Good night, sir. Good night, everybody.
Good night. Good night.